Tell me about yourself and why you want to be an or nurse.
My name is Mihiraa, and I am a registered nurse with a strong commitment to delivering safe, evidence-based perioperative care. Over the last several years of my clinical journey, I have consistently gravitated toward environments that demand precision, proactive planning, and calm decision-making under pressure. What initially began as curiosity during my clinical placements gradually evolved into a clear, purposeful career direction, becoming an operating room nurse. One of the defining moments that shaped my interest in perioperative nursing occurred during my final year theater rotation. I remember observing a complex laparoscopic procedure that required meticulous coordination among the anesthetic team, scrub nurses, and surgeons. What struck me was not just the technical expertise, but the silent, almost seamless teamwork that ensured patient safety at each step. I realized that this was the kind of environment where my strengths, structured thinking, situational awareness, and attention to detail could truly contribute to positive outcomes. Since then, I have worked intentionally to develop competencies aligned with our practice. I completed additional training in infection control, aseptic technique, and surgical instrumentation, and I actively sought opportunities to assist with minor surgical cases in my previous role. This experience helped me refine my ability to anticipate needs, prepare equipment efficiently, and uphold the highest standards of sterility. It also taught me how small lapses can have significant consequences, strengthening my respect for protocol-driven care. What motivates me to transition fully into the operating room is the privilege of being part of a patient's most vulnerable moments, often when they cannot advocate for themselves. I value the responsibility of safeguarding them through vigilance, precision, and teamwork. I am particularly drawn to the blend of technical skill, continuous learning, and interprofessional collaboration that defines our nursing. Overall, I believe that my personality, discipline, and genuine passion for perioperative care make the operating room the ideal place for me to grow and contribute as a nurse.
The OR is a high-stress environment. How do you handle stress and pressure?
I recognize that the operating room is inherently high pressure, where situations can change rapidly and every action must be precise. My approach to handling stress is a combination of preparation, situational awareness, emotional regulation, and effective communication. I firmly believe that stress is best managed before it escalates, so I place significant emphasis on being organized, understanding the flow of the list, and anticipating needs well in advance. One example that reflects how I manage pressure occurred during my time assisting in a busy surgical suite. We were running behind schedule due to an unexpected intraoperative complication in an earlier case, and the next patient had specific equipment requirements that were not initially available. This created tension within the team as the surgeon was concerned about a further delay. My responsibility was to help stabilize the situation, ensure equipment readiness, and contribute to restoring the workflow. I quickly prioritized the essential items, communicated clearly with the circulating nurse and CSSD to obtain what we needed, and reassured the surgeon with accurate updates rather than assumptions. At the same time, I remained calm and focused on safety, double-checking sterility and ensuring no shortcuts were taken despite time pressure. I also reminded the team to pause for a brief equipment check to avoid errors caused by rushing. We were able to start the procedure safely with minimal additional delay. The surgeon later appreciated the controlled manner in which the team handled the situation. More importantly, the patient experienced a smooth and safe perioperative journey. This experience reinforced my belief that maintaining composure comes from preparation, teamwork, and understanding what can and cannot be compromised. In stressful situations, I consciously slow down my internal pace, focus on facts rather than emotions, and always anchor my decisions to patient safety. This mindset allows me to function effectively even in fast-paced, high-acuity or settings.
Describe a time you had a conflict with a surgeon or a colleague. How did you resolve it?
Conflict in the OR is not uncommon, especially when the environment is fast-paced and each team member works under significant pressure. I believe that conflict should be approached with emotional intelligence, respect, and a focus on maintaining a safe surgical environment. One example that stands out in my experience demonstrates how I manage disagreements constructively. During a busy surgical list, I was working with a surgeon who preferred a specific instrument set for a particular procedure. The set was delayed in CSSD due to reprocessing, and the surgeon was visibly frustrated, insisting we start with an alternative set that I knew did not fully meet the procedural requirements. My responsibility was to maintain a safe environment, manage the surgeon's expectations professionally, and prevent escalation while ensuring that patient safety remained uncompromised. I took a calm but assertive approach. I explained clearly and respectfully why the suggested alternative set posed risks and might lead to intraoperative delays or sterility breaches. Instead of simply refusing, I presented a practical solution. I communicated with CSSD to fast-track the tray, prepared all other equipment to ensure immediate readiness, and updated the surgeon with accurate timelines so he felt informed rather than obstructed. I acknowledged his frustration, which helped de-escalate tension, and reassured him that we were doing everything possible to avoid further delay. The surgeon accepted the plan, and we waited for the correct set. The procedure proceeded without complications, and afterward he commented that the transparency and calm communication helped him regain focus. The experience strengthened our working relationship, and he later requested that I join his list again because he appreciated my professionalism under pressure. This situation taught me that conflict can be resolved effectively by staying composed, offering solutions, validating concerns, and always framing decisions around patient safety rather than personal preference.
Where do you see yourself in 5 years?
In 5 years, I see myself as a highly skilled and well-rounded perioperative nurse who has developed strong expertise across multiple specialties within the operating room. My goal is to become someone who contributes not only through direct patient care, but also through leadership, education, and continuous quality improvement. Clinically, I aim to be proficient as both a scrub and circulating nurse in a variety of surgical specialties. I want to reach a point where I can mentor newer nurses, supporting them as they navigate the technical demands and stressors of theater work. I believe in the value of structure preceptorship, and one of my aspirations is to become a preceptor who helps new nurses build confidence, maintain sterile integrity, and understand the reasoning behind surgical workflows rather than simply memorizing tasks. In terms of professional development, I plan to pursue advanced perioperative certifications and training courses, potentially including modules in anesthetic assistance, surgical instrumentation, and patient safety systems. I'm also interested in participating in hospital-based committees focusing on infection control, incident reporting review, or theater efficiency, areas that directly influence patient outcomes and staff experience. Another key goal is to strengthen my leadership skills. While I may not aim for formal management roles immediately, I would like to take on responsibilities such as coordinating lists, supporting team communication, and helping resolve workflow challenges. Over time, I would consider progressing toward roles like clinical resource nurse or team lead if the opportunity aligns with my growth. Ultimately, in 5 years, I want to be recognized as a dependable, knowledgeable, and calm presence in someone who upholds safety, supports the team, and contributes to ongoing improvements in perioperative care. My long-term vision is to grow steadily while maintaining a strong commitment to patient advocacy and high-quality surgical nursing practice.
Walk me through the 3 roles in the scrub nurse, circulating nurse, RN first assistant. What are their key responsibilities?
In the operating room, the perioperative team functions as a coordinated unit, and each nursing role contributes to patient safety through distinct responsibilities. The 3 core roles, scrub nurse, circulating nurse, and RN first assistant, work together to ensure precision, sterility, and surgical efficiency. The scrub nurse is responsible for maintaining the sterile field and directly supporting the surgeon during the procedure. This role requires deep knowledge of surgical instrumentation, sequence of steps, and the ability to anticipate the surgeon's needs. The scrub nurse prepares and arranges instruments, counts items meticulously, and ensures that sterility is never compromised. During surgery, they pass instruments safely, maintain clear visibility of sharps, and monitor sterility throughout the case. Their vigilance helps prevent retained items, contamination, and workflow interruptions. The circulating nurse functions outside the sterile field, managing the broader environment. They coordinate patient positioning, assist with anesthetic preparation, verify documentation, and ensure that all equipment and supplies are available and functional. A key responsibility is performing the WHO surgical safety checklist and supporting effective communication among team members. They respond to unexpected needs, handle specimen management, and maintain accurate intraoperative records. Their situational awareness allows them to recognize risks early and ensure the surgical team remains fully supported. The RN First Assistant, RNFA, takes on an advanced clinical role, working directly alongside the surgeon with specialized training. Their responsibilities may include tissue handling, maintaining hemostasis, using surgical instruments, suturing, assisting with exposure, and contributing to operative decision-making under the surgeon's guidance. They bridge nursing and surgical practice by combining technical skill with patient advocacy. Together, these roles form an interdependent system designed to uphold safety, precision, and efficiency. Each role requires strong communication, clinical judgment, and a shared commitment to protecting the patient at every stage of the perioperative process.
What is the purpose of the surgical timeout or preoperative verification?
The surgical timeout or preoperative verification is one of the most critical safety steps in the entire perioperative journey. Its primary purpose is to ensure that the right patient receives the right procedure on the right site with the right equipment and team. Although it may appear routine, it serves as the final safeguard before an irreversible surgical action is taken. For me as an or nurse, the timeout represents the moment when every team member stops, recalibrates, and aligns their understanding of the planned procedure. In high-pressure environments, assumptions can easily form, especially when lists are long or when cases change unexpectedly. The timeout interrupts that momentum and ensures that the entire team, surgeons, anesthetists, nurses, and technicians, shares one unified mental picture before incision. This synchronization dramatically reduces the risk of wrong-site surgery, medication errors, incomplete preparation, or miscommunication. Beyond confirming identity, consent, surgical site marking, and procedure details, the timeout also ensures that essential equipment, implants, imaging, antibiotics, and safety considerations such as allergies or airway risks are fully addressed. It ensures preparedness for anticipated challenges, from blood availability to special instruments. This structured communication is especially important in emergencies, when speed can tempt shortcuts. Another important purpose of the timeout is promoting psychological safety. When every member of the team pauses together, it reinforces that anyone, from the scrub nurse to the consultant surgeon, has the authority to speak up if something seems incorrect. In my experience, this shared accountability strengthens teamwork and reduces hierarchy-driven errors. Ultimately, the surgical timeout is not just a checklist. It is a culture of safety. It reminds us that even the most familiar procedures deserve deliberate verification. By consistently engaging in thorough timeouts, we protect the patient, support the team, and uphold the highest standards of perioperative practice.
A sponge, needle, or instrument count is incorrect. What do you do?
An incorrect count is one of the most critical safety issues in the operating room, and my immediate response is always guided by established surgical count policies, clear communication, and a firm commitment to preventing retained surgical items. Even if the environment is tense or time is pressured, I treat an incorrect count as a stop point until resolved. During a busy afternoon list, I was the scrub nurse for an abdominal procedure. At closure, the circulating nurse and I performed the final count and discovered that one of the small Ratex sponges was missing. The surgeon was ready to close, and the room was already under time pressure because the next patient was waiting. My responsibility was to ensure that the count discrepancy was fully resolved, prevent a retained foreign object, and communicate the issue assertively but professionally, even if it meant delaying closure. I immediately announced the incorrect count clearly and respectfully, ensuring everyone in the room paused. The circulating nurse and I repeated the count from the beginning and examined all used and unused items. I checked the sterile field, under drapes, beneath trays, and inside the instrument pockets. When the sponge was still not found, I informed the surgeon that we had to follow protocol for a missing item. The surgeon agreed, and we initiated a systematic wound exploration. At the same time, I worked with the circulating nurse to ensure an intraoperative X-ray was ordered, maintaining calm and clear communication to keep the team aligned. The sponge was located inside a suction canister, soaked and difficult to recognize. The final count was corrected, and closure proceeded safely. The surgeon later thanked the team for following protocol, and an incident review reinforced our strong count practices. This experience reaffirmed that patient safety comes above all else, and resolving discrepancies requires confidence, teamwork, and adherence to policy without exception.
How do you maintain a sterile field? What would you do if a break in sterile technique occurs?
Maintaining a sterile field is one of the most critical responsibilities in perioperative nursing. For me, sterility begins long before the incision, through preparation, vigilance, and structure habits. I ensure all sterile supplies are opened correctly, check integrity of packaging, maintain appropriate distance from non-sterile areas, and keep clear boundaries between sterile and non-sterile zones. I position equipment to minimize crossover, monitor movements of the surgical team, and use deliberate, controlled actions when passing instruments. Throughout the procedure, I continuously scan the field for risk factors such as shifting drapes, contamination from fluids, or staff accidentally leaning over sterile areas. If a break in sterile technique occurs, whether suspected or confirmed, I act immediately, even if the theater is busy or the hierarchy is strong. I believe early, transparent communication prevents escalation. During a laparoscopic case, I noticed that a junior staff member inadvertently brushed their non-sterile sleeve against a sterile Mayo stand while adjusting equipment. They didn't realize it happened. My responsibility was to prevent contamination from compromising the patient's safety and to address the issue professionally without disrupting workflow more than necessary. I stopped the activity calmly and stated clearly, "There has been a breach in sterility." I replaced the contaminated instruments, requested a quick field change with assistance from the circulating nurse, and ensured fresh sterile drapes and equipment were brought in. At the same time, I supported the staff member by explaining what happened discreetly, helping them regown and reglove correctly so they could continue safely. I documented the event as per protocol. The sterile field was restored promptly. The surgery continued without incident, and the staff member later thanked me for handling the situation respectfully. The experience reinforced a positive safety culture where speaking up is normalized. Ultimately, maintaining sterility is about constant awareness and the willingness to act immediately, regardless of the situation or pressure in a room.
What are your priorities in preparing a patient for surgery in the holding area?
In the holding area, my priorities revolve around patient safety, verification, emotional support, and readiness for anesthesia and surgery. This phase sets the tone for the entire perioperative journey, so I approach it methodically while ensuring the patient feels informed and reassured. My first priority is accurate verification. I confirm the patient's identity, procedure, surgical site marking, consent, allergies, and relevant documentation such as blood availability, imaging, and preoperative checklists. I collaborate closely with the anesthesia team to ensure all assessments, fasting compliance, and medication reviews are complete. Any discrepancies, no matter how small, are clarified before the patient enters the OR. The next priority is optimizing physiological readiness. I check for access, ensure required preoperative medications have been administered, confirm prostheses or dentures are removed as needed, and assess for issues such as respiratory compromise, pain, anxiety, or baseline vital sign abnormalities. Clear communication with the patient and family is essential, as the holding area can be an emotionally charged space. We once received a patient scheduled for an orthopedic procedure whose consent mentioned the wrong side. My responsibility was to prevent wrong side surgery and resolve the discrepancy before or entry. I paused the process, notified the surgeon, rechecked the clinical notes, and engaged the patient in confirming their understanding. The surgeon reviewed the situation, corrected the consent, and marked the correct site. I reassured the patient throughout to maintain trust. The patient entered the OR safely, and the case proceeded without delay or risk. Finally, I prioritized communication and emotional support. I explain the next steps clearly, address fears, and ensure the patient feels seen rather than processed. A calm, well-prepared patient contributes significantly to a smooth induction and overall surgical experience. My goal is always a safe, well-verified, and emotionally supported transition into the OR.
You are the circulator. The anesthetic has been given, and the patient is being prepped. The surgeon is rushing you to start, but the instrument count hasn't been completed. What do you do?
In the operating room, patient safety is the non-negotiable priority, and no amount of pressure can justify bypassing a critical safety step like an instrument count. As the circulating nurse, it is my responsibility to protect the patient and uphold policy, even when the environment is fast-paced or the surgeon is rushed. During a general surgery list, the anesthetic had been induced, skin prep was underway, and the surgeon was eager to begin because the previous case had run over time. At that moment, our initial instrument count had not yet been completed due to a delay in setting up an additional tray specific to the procedure. My responsibility was to prevent the procedure from starting without a verified baseline count, communicate professionally, and ensure that the surgeon understood the safety implications without escalating tension. I addressed the surgeon calmly but assertively and said, "We cannot begin until the initial count is completed. This is for the patient's safety." I explained that starting without the count would violate policy and put the patient at risk of a retained surgical item. While maintaining respect, I stood firm and immediately supported the scrub nurse in completing the count efficiently by verifying trays, checking packaging, and ensuring all items were accounted for. I also reassured the surgeon by giving a realistic time estimate to help manage expectations, which reduced frustration and kept communication clear. The initial count was completed promptly and accurately, and the surgery commenced safely. After the case, the surgeon acknowledged that maintaining protocol was the right decision and appreciated the composed, solution-focused communication. This experience reinforced my belief that being a strong patient advocate sometimes means saying stop, even when the pressure to continue is high. Safety protocols exist for protection, and as a circulating nurse, I'm committed to upholding them consistently.
During a surgery, the patient's vital signs become unstable, e.g., sudden drop in BP arrhythmia. What is your role as the circulator?
As a circulating nurse, my primary responsibility when a patient becomes hemodynamically unstable is to support the anesthesia team, stabilize the environment, escalate immediately, and ensure that all emergency resources and equipment are available without delay. While the anesthetist leads the medical management, the circulator plays a crucial coordinating and safety-focused role. First, I remain calm and maintain situational awareness. I immediately notify the team that there is a change in the patient's status so everyone shifts attention appropriately. My next priority is to assist the anesthetist by bringing emergency drugs, fluids, airway equipment, the crash cart, or monitoring supplies as requested. I ensure floor access is functioning, help adjust equipment, and document events and interventions accurately in real time, which is essential for clinical decision-making. During a laparoscopic cholecystectomy, the patient's blood pressure suddenly dropped significantly after insufflation, and the anesthetist suspected a vagal response or gas-related complication, and my responsibility as circulator was to support immediate stabilization, escalate appropriately, and ensure the team had everything required to manage the situation. I announced the change in vitals clearly to ensure everyone paused. I assisted the anesthetist by delivering vasopressors, adjusting NIBP cycling, and ensuring suction and airway backup were ready. I alerted the surgical team to stop insufflation, prepared for rapid conversion if needed, and brought the crash cart closer. I also updated documentation and arranged for arterial blood gases as requested. The patient stabilized within minutes, insufflation was safely resumed, and the case proceeded without complication. Throughout any instability, my role is to communicate clearly, anticipate needs, maintain safety, and ensure rapid access to all critical resources. Remaining composed and proactive allows the entire team to function effectively during an acute physiological change.
A family member stops you in the hallway, extremely anxious, and demands detailed information about the surgery in progress. How do you handle this?
When a family member approaches me anxiously during surgery, my priority is to balance empathy with confidentiality while ensuring their concerns are acknowledged and addressed appropriately. I recognize that families often feel powerless during this period, so I approach them calmly, respectfully, and with clear professional boundaries. First, I make sure to validate their emotions. Instead of dismissing their worry, I acknowledge their anxiety and convey that their loved one is being cared for safely. At the same time, I maintain strict confidentiality by avoiding any clinical details unless I am the designated person authorized to speak on behalf of the surgical team. During a busy theater schedule, a patient's relative stopped me in a hallway, visibly distressed, and urgently asked for detailed updates about the ongoing procedure, including duration, complications, and expected outcomes. My responsibility was to preserve patient confidentiality de-escalate the relative's anxiety, and ensure they received appropriate communication through the correct channels. I paused, maintained a calm posture, and validated their concern by saying, "I can see how worried you are, and it's completely understandable." I then explained kindly but firmly that I wasn't able to provide detailed clinical information because I was not the assigned liaison, and the team was still operating. Instead, I offered a safe alternative. I guided them to the waiting area, contacted the designated or liaison nurse or surgeon's representative, and ensured someone responsible for communicating updates was aware of the family's distress. I stayed with the relative briefly until support arrived, helping to reduce their immediate anxiety. The family felt heard and supported, and the appropriate clinician later provided them with an accurate, authorized update. The situation de-escalated smoothly, while confidentiality was fully maintained. This reinforced my belief that compassionate communication and firm professional boundaries must work hand in hand to protect both patient privacy and family well-being.
The field of surgery is constantly evolving with new technologies, like robotics or new implant systems. How do you approach the challenge of learning and adapting to new techniques and equipment?
The surgical environment evolves rapidly, and as an ER nurse, I see continuous learning as essential for maintaining safe, high-quality care. My approach to new techniques, technologies, or equipment is grounded in proactive learning, hands-on practice, structured reflection, and collaboration with experts. When new technologies such as robotic systems, energy devices, or implant systems are introduced, I begin by familiarizing myself with the theory behind them, manufacturer guidelines, instructional modules, and safety protocols. I then seek opportunities for simulation training or supervised practice, which allows me to understand functionality, troubleshooting, and workflow integration before applying it in a live surgical setting. I also actively learn from senior scrub nurses, surgeons, and clinical educators, asking focused questions to ensure that my knowledge is practical and procedure-specific. When our theater introduced a new minimally invasive robotic system, many staff felt overwhelmed due to the complexity of its docking, console communication, and instrument management. My responsibility was to learn the system thoroughly so I could support cases safely and help the team adapt during the transition. I attended the vendor-led training, reviewed manuals, and practiced repeatedly in the simulation lab. I scheduled time with the robotic coordinator to observe setup and takedown steps, and I created a small reference sheet for my colleagues summarizing troubleshooting tips and instrument sequence. During early live cases, I stayed one step ahead by anticipating needs, ensuring safe instrument exchanges, and clarifying communication between the console surgeon and bedside team. I became one of the early staff members independently competent with the system, and surgeons later requested me for robotic lists because of my calm, organized approach. The quick adaptation also improved our efficiency and reduced setup errors. This experience reaffirmed that embracing new technologies requires curiosity, consistency, and teamwork, and I apply this mindset to every innovation that enters the OR.
Aside from the surgical count, can you give an example of a seemingly small detail in the OR that has a major impact on patient safety or the flow of a case?
One seemingly small detail in the OR that significantly impacts both patient safety and surgical flow is proper positioning and securement of the patient before draping. It can appear routine, but even a minor lapse, such as inadequate padding, incorrect limb alignment, or unsecured equipment, can lead to nerve injuries, pressure ulcers, airway compromise, circulatory issues, or intraoperative delays. I have learned that meticulous attention to positioning avoids long-term complications and supports optimal surgical access, anesthetic stability, and procedural efficiency. During an elective urology case, the surgeon requested a lithotomy position. The room was busy, and we were slightly behind schedule. A junior staff member prepared the stirrups quickly, but I noticed the patient's right leg was positioned slightly higher than the left, and the padding around the peroneal nerve area was not symmetrical. My responsibility was to ensure safe, anatomically correct positioning and prevent potential nerve injury, even though correcting the setup could cause a small delay. I asked the team to pause and explain that we needed to reposition and repad the legs to avoid common peroneal nerve compression. I coordinated with the anesthetist to ensure hemodynamic stability while adjusting the stirrups. I also confirmed that the sacrum was aligned, heels were free, and all pressure points were appropriately padded. Although it required a few extra minutes, I completed the safety check thoroughly. I then communicated with the surgeon, giving a clear and concise update to maintain trust and transparency. The case proceeded smoothly, and the surgeon later acknowledged that the attention to positioning prevented postoperative complications. The patient recovered without any nerve symptoms, and the debrief reinforced the importance of prioritizing positioning checks regardless of time pressure. This experience reminded me that in the OR, minor details are never minor, and vigilance in fundamentals is what protects patients the most.
Imagine you are scrubbing in and passing instruments. You notice the surgeon is about to make an error, such as preparing to use the wrong graft or implant for the procedure. How would you address this at the moment?
In the operating room, preventing an error is far more important than avoiding discomfort or hierarchy. If I notice that the surgeon is about to use the wrong graft or implant, I intervene immediately, clearly, and respectfully. My priority is to protect the patient, and I rely on professional communication grounded in policy, not personal opinion. I firmly believe that clarity saves time and lives. Rather than hesitating or hinting, I use a direct, factual, and non-confrontational statement such as, "Before we proceed, I need to clarify, the implant selected does not match the one documented for this patient." This stops the action, prompts verification, and signals to the entire team that a safety pause is needed. During an orthopedic case, the surgeon reached for a size and type of implant that didn't match the preoperative plan. The trays contained multiple similar-looking components, and the case was running behind schedule. As the scrub nurse, I had to stop the error from reaching the patient, verify implant accuracy, and communicate assertively while maintaining a calm surgical atmosphere. I immediately said, "Doctor, before you open that, the implant label doesn't match the plan size on the checklist." My tone was respectful but firm. I kept my hand away from passing the item and asked the circulator to bring the printed implant plan and confirm the catalog number. We cross-checked the labels, the surgical plan, and the imaging. The surgeon realized the wrong implant had been selected due to similar packaging. I presented the correct implant tray promptly, allowing the procedure to continue safely. The case proceeded without delay, and the surgeon later thanked me for speaking up. The incident reinforced a culture where safety override hierarchy. Ultimately, my approach is simple: patient safety first, always. If I see a potential error, I stop it professionally, confidently, and immediately.
Describe a situation where you had to advocate for a patient who could not advocate for themselves. What was the situation and what was the outcome?
One situation that stands out happened during my time in the OR with an elderly patient undergoing a hip fracture repair. The patient had advanced dementia and was fully dependent on staff for communication and decision-making. During the preoperative verification process, I noticed that the consent form listed the left hip for repair, but the clinical notes, X-ray, and the initial ED assessment all indicated a right-sided fracture. The patient was unable to confirm, and the family member who signed the consent was not immediately reachable. Even though the surgeon and team were preparing to proceed, I paused the workflow and respectfully stated, "I'm not comfortable moving forward until we reconcile this discrepancy. The documentation isn't consistent with the site mark." I immediately escalated the concern, contacted the orthopedic resident, and used the institutional timeout protocol to halt all steps. After a review of imaging and a call to the family member, it was confirmed that the right side was correct. The consent was updated, the site was verified, and we proceeded safely. The surgeon later thanked me for speaking up, and the incident was even used as a positive example in our departmental safety meeting. For me, this situation reinforced that advocacy is not an optional skill in the OR. It is central to patient safety, especially for vulnerable patients who rely entirely on the team to protect them. I am always prepared to stop a case, even if it feels uncomfortable, because preventing harm is the highest priority.
A never event like a wrong side surgery is every OR team's worst fear. Beyond the timeout, what specific steps do you take as a circulator or scrub nurse to personally ensure this never happens on your watch?
To prevent a wrong site surgery, I focus on creating multiple layers of verification long before the timeout begins. As the circulator, I start by ensuring that every document, consent form, surgeon's notes, imaging reports, and the OR schedule matches perfectly. If there is even a slight inconsistency, I stop the process immediately and escalate the concern before the patient enters the theater. I also make sure the surgical site marking is present, legible, and performed by the surgeon, and I verify that the patient can confirm the correct site whenever possible. I treat that confirmation as a critical safety check, not just a formality. Once in the OR, I maintain continuous situational awareness rather than relying solely on the formal timeout. As I position the patient, prep, and set up equipment, I'm constantly cross-checking that the site and procedure align with what I have verified. If there are implants, laterality-specific devices, or side-dependent equipment, I consciously lay out or open only what matches the confirmed operative site. This creates an added safeguard because any mismatch becomes immediately obvious. If I am scrubbed, I maintain the same vigilance. When the surgeon asks for an implant, graft, or tool that is site-specific, I pause for a second internal check against the case details. Even during routine tasks like preparing instruments or draping, I stay alert for subtle cues that something doesn't match the plan. Most importantly, I give myself permission to speak up instantly, clearly, and confidently if something doesn't look or feel right. I use assertive language, and I do not allow hierarchy or time pressure to override patient safety. I remind myself that hesitation is more dangerous than being wrong. If I need to halt the room for a moment of clarity, I do it without apology. Maintaining this proactive, vigilant mindset throughout the entire perioperative process, before, during, and even after the timeout, is how I personally ensure a never event does not occur on my watch.
How do you handle a long, physically demanding case that requires intense focus for many hours? How do you maintain your performance level from start to finish?
A well-developed, interview-ready answer might sound like this. Handling long, physically demanding cases requires a blend of preparation, self-awareness, and disciplined focus. Over time, I've learned that maintaining high performance isn't something that happens spontaneously. It requires deliberate strategies before, during, and after the procedure. Before a long case, I make sure I am well-rested, properly hydrated, and have eaten in a way that supports sustained concentration. I also take a few minutes to review the case, anticipate the phases of the procedure, and mentally rehearse my role so I begin the case with clarity rather than tension. During long surgeries, I rely on structured focus rather than trying to stay intensely concentrated for hours at a stretch. I use what I call micro-resets, which involve consciously relaxing my shoulders, adjusting my stance, taking one deep breath, and scanning the field or room to regain situational awareness. These small resets take only seconds, but prevent both mental fatigue and muscle strain. If I am scrubbed, I make sure my positioning protects my back and neck, and I shift my weight subtly to avoid stiffness without compromising sterility. If I am circulating, I move purposefully and avoid unnecessary exertion, conserving energy for critical moments. I also maintain quiet communication with my team, confirming next steps, anticipating needs, and staying engaged, because active involvement naturally sustains focus. There was a particularly memorable case that lasted nearly 11 hours. Around the midpoint, the surgeon requested a complex sequence of instruments for a grafting stage that required precise timing. I realized fatigue was setting in, so I consciously performed a micro-reset, double-checked the sequence, and reminded myself of the high-risk nature of that surgical step. That intentional pause prevented an instrument sequencing error and allowed the grafting stage to proceed smoothly. By the end of the case, although exhausted, I was still performing with precision because I paced myself rather than trying to power through. Finally, after long procedures, I debrief with team members and take note of how my body and mind responded. This reflection helps me refine how I prepare for future demanding cases. Overall, maintaining performance during long surgeries is about discipline, anticipation, and understanding my own physiological limits while never compromising patient safety or team coordination.
Walk me through the correct process for handling and labeling a critical specimen, such as a potentially cancerous mass.
Handling and labeling a critical specimen, especially one that may determine a cancer diagnosis, requires absolute precision, clear communication, and a strict adherence to chain of custody principles. I approach it as a zero-tolerance task where even a small lapse can lead to misdiagnosis, delayed treatment, or the need for repeat surgery. My process begins the moment the specimen is removed. I verbally confirm with the surgeon what the specimen is, its orientation, and whether margins need to be marked or inked. I repeat this information back verbatim to ensure mutual clarity, because assumptions at this stage are the greatest source of error. If I am scrubbed, I ensure the specimen is placed in the correct container immediately, using appropriate fixative and maintaining proper orientation, such as suturing or tagging specific edges when required. I also communicate every detail to the circulator without distraction or interruption. As the circulator, I receive the specimen in a structured handover, confirming patient name, hospital number, specimen type, laterality, anatomical location, and any special instructions like frozen section or urgent pathology. I label the container before it leaves my hand, never after it is set down, and I ensure the label matches the consent, the operative note, and the surgeon's verbal description. Before sending it to pathology, I double-check that the requisition form mirrors the container label exactly, including clinical history and required tests. If there is anything unclear, such as margins, orientation, or the exact anatomical descriptor, I stop and reconfirm with the surgeon, even if the room is busy or the next stage of surgery is starting. I physically escort critical specimens to pathology rather than leaving them unattended or sending them with someone unfamiliar with the case flow. My priority throughout is maintaining an unbroken chain of verification, surgeon to scrub, scrub to circulator, circulator to pathology. This ensures the specimen is correctly identified, preserved, documented, and delivered, protecting both diagnostic accuracy and patient safety.
The surgery is finished, and the surgeon is leaving. What are your key responsibilities as the OR nurse during patient transfer to PACU?
At the end of a surgery, even though the procedure itself is complete, I see the transfer to PACU as an equally critical phase because the patient is at their most vulnerable point, anesthetized, physiologically fragile, and unable to advocate for themselves. My responsibilities focus on ensuring a safe, seamless, and well-communicated transition of care. As soon as the final count is confirmed correct and the sterile field is broken, I shift my attention to preparing the patient for transport. I verify that the airway is secure, that all monitoring leads, invasive lines, drains, and catheters are appropriately positioned and functioning, and that nothing is tugged, kinked, or removed unintentionally. I double-check dressings for bleeding, confirm that the operative side is supported, and ensure all equipment such as surgical drains, chest tubes, or wound vacs are portable and correctly clamped or set for transport. Communication is fundamental at this stage. I collaborate closely with anesthesia to ensure the patient is stable for transfer. If I am the circulator, I gather all essential documentation, operative notes, implants used, anesthesia records, specimen details, and intraoperative events such as blood loss or complications. I make sure everything is complete and accurate because missing information can delay or compromise postoperative care. I accompany the patient to PACU with the anesthetist, ensuring continuity and situational awareness throughout the move. Once in PACU, I provide a structured verbal handover using a standardized tool such as SBAR. I clearly outline the patient's baseline status, the procedure performed, anesthesia type, intraoperative concerns, analgesia administered, fluids and blood products given, airway considerations, and any surgeon-specific postoperative instructions such as limb positioning or neurovascular checks. I remain present until the PACU nurse confirms they have received all critical information and the patient is safely connected to monitors and oxygen. My final responsibility is ensuring the patient's dignity and comfort, clean linens, appropriate warming measures, and maintaining privacy. Even at the end of a long case, I do not rush this process because the quality of the handover directly affects the patient's immediate recovery trajectory and overall surgical outcome.